Good day. My name is Sri Aparupa Jasti, and I'd like to talk to you about a high-yield board topic. This is also something that comes up in daily medicine rounds. Heparin Induced Thrombocytopenia, or HIT. Let's begin. What are the various types of HIT, and what difference does it make in identifying which type it is? Well, based on the type, the treatment differs. So a really simple way to remember it is by the time since exposure to heparin. If you see a sudden platelet drop within 1 to 2 days, it is type 1 HIT. If it occurs within 5 to 10 days, it is type 2 HIT. If you notice it a couple of weeks later, but within 20 days, it is delayed onset. This may occur sometimes after discharge from the hospital, and you may see the patient in the clinic setting. Type 1 HIT is non-immune mediated and occurs due to the direct effect of heparin on platelets, which causes them to clump together. Platelet counts sometimes drop below 150,000. It's a benign condition and does not require any treatment. Type 2 HIT is immune mediated and occurs due to antibodies against platelet factor 4. What you have to watch out for is for any sort of thrombus in the patient, a pulmonary embolism, a deep venous thrombosis, or an acute arterial thrombus. Treat these patients with a direct thrombin inhibitor such as argatroban. Delayed onset is true to its name. It can occur a couple of weeks after exposure, anytime within 20 days. It's very similar to type 2 HIT, as it is also immune mediated and is a more severe reaction with a higher titer of antibodies against platelet factor 4. You treat these patients with argatroban or a direct thrombin inhibitor as well. The two main tests you have to remember to order in the hospital setting are serotonin release assay and heparin-induced platelet aggregation assay. ELISA for heparin platelet factor 4 complexes is a screening test and is done if you have low suspicion and you want to rule out HIT. If it's negative, you have ruled it out. If it's positive, you move on to the confirmation tests. The treatment is to stop heparin immediately, listed as an allergy on the patient's chart, and begin argatroban or any other type of direct thrombin inhibitor, like bivalirudin or fondaparinol. Wait until the patient's platelet counts have improved, and then switch to warfarin. If there is a clot present, the treatment duration is 6 months. If there is no clot, the treatment can be terminated within 3 months. Why can't we use warfarin right away? Warfarin inhibits protein C and protein S production, which are anticoagulants in the blood, and it also decreases coagulation factors. So treating with warfarin initially may temporarily make clotting worse. I have also not gone into detail about the 4T scoring system. It's easy to look it up online if you need it, and I wanted to focus on what you really need to remember to identify HIT in clinical practice. Thank you for listening.